Welcome back, guys, to another episode of Hormones Happen. I'm your host, Jeremiah, and I've got a very special guest with us today. She's a nurse practitioner who was in cardiology for 10 years, putting her desire for wellness. In 2025, she opened Vitalux Wellness and Aesthetics. Crystal, thank you for being with us.
Thank you so much for having me.
So, cardiology to wellness, that's quite a jump. What was the catalyst that made you say, hey, I'm going to go all in on this?
Absolutely. So that's a great question. After treating really sick patients, both in the hospital and in the clinic, I almost felt like I was just spinning the hamster wheel. Like there was no means to an end for these patients to finally get better. I was just, constantly throwing medication after medication to them. And a lot of these patients also didn't understand. They didn't understand how they got here, how to prevent these types of situations from happening, and how to kind of not go down this road to begin with. They whenever they would come to us in cardiology, at that point they were very, very sick. And so it was really disheartening to see that nobody ever taught them how to take care of themselves or preventative medicine from the get-go, for a lot of those patients.
Yeah. My nursing career started in cardiology, actually, and that was my first introduction into seeing recurrent patients coming in, the same patients every single time. And the only thing that would get added on is diagnosis, medication. And it kept rotating. Just like you said, it was a hamster wheel. And it was unfortunate because it's like the last admission, this guy was doing okay. And now he's almost dead. And you just see it progress and progress and progress. And it's just a true testament to the lack of our ability to focus on prevention, right? And we're so reactive. And cardiology, I think, is very, I don't want to say notorious for this, but there's a lot of prevention in cardiology and a lot of focus on it. So that was something that really opened my eyes as an RN in cardiology. But real quick, tell us, what state are you in? What states are you licensed in? And what kind of services do you offer?
Yeah, absolutely. So I'm currently licensed in Texas. My primary clinic is in Texas, in Lipan, which is just west of Fort Worth. And then I'm opening a second clinic in the next few weeks, about 45 minutes south of me, which will be in Glen Rose, Texas. I also offer virtual visits through the entire state of Texas. And then I'm also licensed in Nevada, New Mexico, Oklahoma, and then soon to be expanding to other states as well.
Wow, that's awesome. And you treat men and women, correct?
Absolutely. Absolutely.
Perfect. So I first heard about you on TikTok. I love your TikTok. And just recently you made a post about self-doubt. And that really struck a chord with me because I can't tell you how many times self-doubt has almost derailed everything. And so my question to you is, what kind of things have you done to help navigate around the self-doubt associated with starting your own practice?
Yes. Those feelings still creep back in, especially whenever you're with me opening a second practice. Those self-doubt feelings still kind of creep back in, like, am I ready? Am I going to be busy enough? Is this something that's going to make it? But you just have to kind of take that risk, and you have to be passionate about what you do. So I started my practice with the goal of prevention and focusing on prevention and getting people better and preventing them from going down that road of chronic illness, because I saw it so much, in the cardiology realm. And there was so much that I wanted to change in the way that we treat patients, the way that we approach medicine, and the way that we approach chronic illness. I want to try to get things from the forefront to prevent you from having these recurrent hospital admissions, from having these, long chronic health complications, because it's a snowball effect. Once you get one diagnosis, then you get another, then you get another. And they all are so, coincide with each other, like diabetes, followed by hypertension, followed by hyperlipidemia, followed by coronary artery disease, followed by congestive heart failure. I mean, it's just, and so if you could back way up and start with the prevention of diabetes, then a lot of times you can prevent those snowball effects from those other chronic health conditions. I know there's a lot of hate out there about nurse practitioners and becoming entrepreneurs and independent practice. And there are some points that I agree with. I had a very, very solid foundation where I worked very closely with multiple cardiologists and was trained very well by them. And I would not say that right out of school I was ready to have independent practice. Absolutely not. I trained very closely in acute and outpatient settings with these cardiologists for 10 years, and I would say it took at least 3 to 4 years before I truly felt comfortable seeing my own patients, making diagnoses, and know where to look for answers. And medicine is just that, it's practicing an art. So nobody is going to have it perfectly. And it is something that you continually, the more that you do and the more that you expose yourself to, the more practice that you get. You have to be kind of open-minded as well, and say, and your patients appreciate that. If you say, look, we may not get this right on the first try, but this is where we can start, and then we'll reevaluate and we may have to change directions. And they really appreciate that honesty. And so I think that that has really been kind of a launching pad for me, because I'm very forthcoming with my patients. I say, especially with hormonal care, nothing is black and white. You cannot treat a patient based, this is the lab range, this is where we have to stay. You tell them, we'll try this, we'll reevaluate in a few weeks. It's incredibly customized and individualized. So if this isn't working for you, let's try something else. And I think that that really, resonates with those patients whenever they're looking for care.
I absolutely love the transparency because the reality is we don't know everything, and it doesn't matter whether you're an NP, a PA, MD, DO, we don't know everything. And guess what? The world of hormone replacement therapy is still the Wild West. It always will be. I learned so much from my patients, right? At the end of the day, doesn't matter what your credentialing is, who has the most time to study, who has the most time to research, and then also realize people aren't just study populations, right? So the studies guide us, but they don't dictate treatment. And the reality is we have to individualize it, just like you were saying, right? You listen to the patient and we're forthcoming with, I don't know everything. This may work. I hope it does. But that was something that I really struggled with initially starting. And that was a huge source of self-doubt is I don't have the answers. How do I tell them I don't have the answers? They're paying me for answers and I don't have them. But you know what? They just want someone that's willing to work through these problems with them, someone that's going to listen to them. They don't want to hear all the facts and the stats. They want you to hear them. And
Exactly.
so, yeah. And so one thing that I always love about your TikToks is the focus on women's health, because I think we can both agree it's very neglected. It's not something that we discuss enough. And unfortunately, there's a lot of negative stigmas behind hormone replacement therapy specifically for women. And there was one post that you made that I absolutely loved. If a female had a hysterectomy, do they still benefit from progesterone?
Absolutely. Absolutely. So, and that's, I actually get a lot of women who are post hysterectomy. I've had a few, even young women in their 20s who've had hysterectomies for endometriosis or adenomyosis, who that was kind of their last ditch effort, talking through their specialist, their gynecologist or whoever, and they will put them on just estrogen replacement therapy. If they even do that, I've even had patients who have had full hysterectomies, oophorectomy and their uterus removed and have had no hormones. And it just
Crazy.
baffles me. And it's just such a disservice to those patients. But to answer your question, yes, absolutely still benefit from progesterone. I think that this goes back to just listening to women, listening to them. If they're saying that they're having these symptoms and it's not fixed with just estrogen, we need to try something else. Yes, the guidelines say the only time that you are required to add progesterone is if they still have an intact uterus to prevent that uterine hyperplasia that can lead to endometrial cancer and such. But there are so many other benefits of progesterone with women, whether or not they have a uterus. If you're a woman, you still need those progesterone levels to help with sleep, to help with irritability, to help with anxiety, to help with night sweats. I mean, the list goes on and on.
A- Absolutely. It is such a disservice. I can't tell you how many women I've had come in for a consult and say, I've been told that I can never be on progesterone because I don't have a uterus. That makes no sense at all. Why? Why do you have to have insomnia? Why do you have to have anxiety? And granted, estradiol helps with these things, so does testosterone, but progesterone plays a very specific role by upregulating GABA A receptors in the brain. That's what it does. This is a neurotransmitter that makes you feel good. We call it the Valium of the brain for a reason. And I can't tell you how many times someone will come in, even on HRT, they've had hysterectomy, they are missing that progesterone component. And it's as clear as day. That is what we are missing.
Absolutely. I cannot agree more with that. Absolutely.
So let me ask you this. If you had a female come into your office, what are some of the most common symptoms you hear reported regarding that transition from that perimenopause to menopausal switch?
Yes, absolutely. So many of the times it's usually women who are in their late 30s, early 40s, and they will come in and they say, I am just so angry. I'm irritable all the time. Something has changed. I don't feel like myself. My husband's driving me crazy. My kids are driving me crazy. I don't know what's going on. I just do not feel like myself anymore. Please help. And will say that they've gone to their primary cares or even to their gynecologist and say that they want their hormones tested, and their gynecologist or their primary cares will either dismiss them or they'll start them on an SSRI. And it's not really addressing what is happening and what that major biological shift is that women go through whenever they're in their late 30s to early 40s. Addressing these hormonal fluctuations and this just kind of roller coaster. I think there's such a lack of knowledge of that transition and what that looks like for women who, typically whenever you think of a menopausal woman, you think of this old gray haired lady in her, 50s. That's not the case. You can start symptoms of perimenopause up to 10 years prior to actually going through menopause, which is, that 12 months without a cycle. But those hormone fluctuations can start in your 30s. So you don't have to be old with gray hair to start experiencing symptoms
Yeah.
of perimenopause. And I think that a lot of women are just dismissed as having anxiety or a mood disorder whenever it's truly a biological problem. It's they just need that little extra because those progesterone levels have now fallen below their threshold to where they become symptomatic. And simply adding that little bit of progesterone at night, it can be life changing.
Yeah. So if I'm hearing you correctly, what you're saying is we should start HRT in perimenopause.
Absolutely, absolutely. And there
Love it.
actually was a article the North American Menopause Society just put out saying that estrogen has a significant benefit whenever you start that in perimenopause rather than waiting until they're fully through menopause, that 12 months without a cycle, or waiting until your FSH level has risen. There's significant benefit of starting estrogen replacement therapy prior to that, and it's a compounded benefit. So the longer that you're on it, the longer you keep those estrogen levels high, the more benefit you have. It's a 60% risk reduction in heart attack, stroke, and breast cancer. I mean,
That's amazing.
where else can you get this chronic disease, risk reduction? Where else can you have that?
Oh, that is amazing, but it also makes me upset. It makes me upset that we know what's causing these significant, life-changing, debilitating conditions, and we're doing nothing about it. We have the research, we have the data, but we say, you know what? In a primary care office that takes insurance, it's like, sorry, you've got to have crippling conditions in order for us to even consider this to be something that would value or benefit you. And I couldn't agree with you more. That estradiol is so incredibly important. It does so many things. We're talking bone protection, heart, brain protection. And the longer we're without sufficient estradiol levels, we've already started the countdown timer, right? Every single year is a significant increased risk. And that is why women who are 10 years postmenopausal, there are certain situations and caveats and conditions we need to think about starting them on HRT. Granted, I have women in their 80s on HRT, right? And it's
Absolutely.
amazing to see them regain their life, regain their confidence. One thing that I always get a kick out of is the libido. I always love this because this is a thing, right? Libido and intimacy is so important for relationships. And when someone comes in and says, hey, I've been married for 30 years and we are struggling so much because of this libido issue, I get her optimized. She drags her husband in saying he cannot keep up. Can you help this guy? It's just a wonderful thing. And also the validation, right? Going your whole life being told, hey, welcome to the club. This is normal. Sorry, your hormones are normal. And never getting that validation, but you finally are treated by someone and you feel better. And you now know, hey, I never was crazy. This is very validating. People tell me I'm crazy, right? Do you hear that all the time?
Yes, that's a very good point. I think, we have made leaps and bounds in even the short time that I've been in hormone replacement therapy and treating women for this. There have been leaps and bounds in a large, kind of public realization that this is a transition that women go through. I think, everybody, or at least from a woman's perspective, you will talk about starting your period, having your first cycle, but nobody talks about kind of that second puberty that hits you
Yeah,
and
right.
what that's like and that huge hormonal shift, and so women who are, starting to experience these symptoms, like I said, even in their mid 30s, you can start with night sweats, you can start with irritability, you can start with decreased libido, and not realizing this is not an underlying, mood disorder or psychiatric disorder. This is something that's biological. This is something that needs to be looked into and treated. And I think, a lot of OB-GYNs kind of miss the mark whenever they tell patients, well, we don't need to test for labs for perimenopause. No, there is not one single lab test that will give you an answer and say, if this lab equals this, then you're in perimenopause. It's definitely not the case. It is a clinical diagnosis. But I think that it also offers patients some reassurance that, okay, this gives me some objective data to look at, especially regarding things like testosterone levels, and to say, okay, I feel good when my testosterone level is this versus when it was in the toilet.
Right. And I love the fact you brought up testosterone because this is something that a lot of people miss the mark on. I've had some women in my office and we're going over their lab work. We'll get to testosterone and they see they have a little bit, just a drop, and they'll freak out. Oh my God, that's a guy hormone. I shouldn't have any of that. What is going on? And the reality is this is one of the most beneficial hormones you could possibly have. What are your thoughts on testosterone replacement therapy?
Love it. I love it. I love it. No, truly, it's definitely needed. So from the time that women are in their kind of late 20s, that testosterone level is on a steady decline and it just continues to decline until you reach full menopause where you're no longer producing it and it becomes basically undetectable. But testosterone is so important for so many bodily functions for women, not just libido. It's known as the sex hormone. It's known as the libido, to increase your libido. And that's what women primarily think about, or the public primarily thinks about whenever they think of testosterone. But testosterone in women does so much more. Mood, motivation, energy levels, all of those things are influenced by testosterone. It very much influences your brain just as much as it does your genitals.
Yeah, absolutely. I've had several patients who have felt very uncomfortable with testosterone. And, of course, I kind of talk to them about, hey, estradiol and progesterone, awesome, amazing. They may not fully resolve your symptoms. And sure enough, right, we're optimizing estradiol, optimizing progesterone. That testosterone is the missing piece because it does so much. Because remember, our body makes all three of these hormones in unison. For us guys, we're very lucky. Our hormones just dwindle down over time. With females, not only are you cycling your hormones, but then you just hit this cliff called menopause where 50% of your hormone production just right out the window. Now we're relying on the adrenal glands. And the reality is, our body wants all three of these hormones. It's very rare that I see someone just benefit from one individual hormone for very long. And so those are just some of the very specific intricacies when treating patients. Now, what are your preferred methods of replacement?
Yeah, absolutely. So, progesterone, I always prescribe as a pill that you take at night. That is our first line to try to replace progesterone, because you get those benefits of helping with sleep. You get the GABA, you get all of those wonderful effects. Now, I will have patients that come to me that say that they're progesterone intolerant or that they've tried birth control in the past and it made them crazy and they had mood disruptions from it. And it's, simply an education session between me and the patient. And I have to explain to them the progesterone, which is not really progesterone, it's progestin, in birth control pills is not the same thing as bioidentical micronized progesterone. It hits two totally different receptors. And so if you've taken, for example, a progesterone only birth control pill in the past, such as the mini pill is what it's known as, and you reacted negatively, especially in regards to your mood, a lot of women will have irritability and just mood swings with those kind of birth control pills. And then we try identical progesterone at night, and it's night and day. There's no comparison because it targets different receptors, because they're molecularly different. They don't perform the same function in your bodies. All that to say, typically progesterone is the pill that I give at night. Some side effects of progesterone, you may have some bloating. Sometimes you may have a little bit of water retention. If that happens, then we can switch to a troche, which is kind of like a lozenge, a melt away that they'll take, and that kind of bypasses those GI effects. And sometimes they don't get as much sedating effects from the troche form, but they still get some mood and some anxiety relief from that. Estrogen, it depends. I do perform pellets and I do love pellets for women. So if I know that they need testosterone and we're going to go the testosterone pellet route, obviously we'll go estrogen pellet because you'll be able to do both of those hormone replacements with one method. If we're not going the pellet route, then I like an estrogen patch because it has the lowest risk in regards to clotting risk. With oral estrogen, there is a slightly increased clotting risk. It's not huge. It's not a deal breaker. And as long as you have not had prior clots in the past, like DVTs, PEs, those sorts of things, then usually you are still a good candidate for oral estrogen. And it's cheap, it's generic. So I'm definitely open to that. But my first line is an estrogen pack if we're not doing testosterone pellets. And then testosterone for women, I love either the pellets because it's so easy. It's once every 3 months. You're perfect. You're good to go. And then if they prefer to not go the pellets, then I like testosterone injections for women. And
Awesome.
I
Yeah.
do that once or twice weekly, either 10 milligrams twice a week, 20 milligrams once a week, somewhere around there, and then kind of titrate it based on their labs and their symptoms.
That's awesome. And the takeaway of all this is there is no wrong way to do it. People will say, oh, I hate the pellets. I hate the injections for women. Guys, there's no wrong way to do it. You really have to experiment, right? Some women prefer the creams. Some hate the creams. Some love the injections. Some love the pellets, right? Every 3 months, that's really, really nice. I absolutely love the oral micronized progesterone as well, right? Because when we're talking about the sedating anxiety effects, we want that first pass metabolism through the liver because that's what's breaking it down to allopregnanolone. And that's the metabolite that upregulates those GABA A receptors. There's 1,000 different ways to do this. I've talked to some practitioners that say for progesterone intolerance, they'll even do like a DHT blocker because DHT is basically the 5-alpha reductase converts the progesterone to allopregnanolone. But then the question is, well, what's going to happen to our androgens? Believe it or not, women also need DHT. So we kind of get into the sticky situation there. Creams, okay, sure, that's an option, but is it still protecting the uterus to the same degree? There's always these things you have to think about, right? I even had one practitioner who had a lot of success using oral micronized progesterone taken intravaginally. And she said that worked fantastic. You're not getting the neurocognitive effects because some women will say, I felt drunk for the whole day.
Yes. Yes. I have had I've had one patient who, yes, she actually called me about an hour after she had taken her oral micronized progesterone, and I asked her, I'm like, "Are you okay?" I was actually concerned for her because she was slurring her speech, and she's like, "No, I'm trying to show you this is what I feel like after I take my progesterone." And it was a low dose. I want to say it was like 100 milligrams. And I was like, "Okay, well, let's stop that. And let's definitely try to figure out." And we switched her to the troches, and she did beautifully. She still had that uterine protection because she still had a uterus. We had her on an estrogen patch. So we switched her from the oral to the troche, and perfect. She tolerated it wonderfully.
Beautiful. Yeah, I'll have to try to implement some of those troches. And then, so I guess the thing is, when someone is saying like, I don't think these hormones are enough as far as dosage, what are some things you look for? Like, what are some symptoms you're looking for? What are some end goals you're looking for as far as treatment?
Yeah. So, we definitely want to look at their presenting symptoms and make sure that we're not missing anything else. The answer to a lot of symptoms is not always going to be hormones, so you're not going to completely erase somebody's fatigue who has severe obstructive sleep apnea and doesn't use a CPAP by adding testosterone. You still have to look at the patient as a whole picture. And that's why it's really important to go to go to a provider or to a practitioner who has this kind of also internal medicine, general medicine experience and can look at the patient and say, okay, if they have a thick neck or if they snore, you likely have underlying sleep apnea. We definitely need to get that treated in conjunction with your hormone replacement therapy to be able to get the best benefit and symptom relief without having any side effects. Especially speaking of sleep apnea, those patients, whenever you recheck their blood work, if they have a high hematocrit, a lot of people will just jump on and blame the testosterone and say, well, you need to go donate blood because your hematocrit's high because you're taking testosterone. Well, you look at them and, they've got severe sleep apnea, and that's the reason for their high hematocrit. You treat that and the hematocrit gets better and everybody's happy.
Yeah, it's really, really easy to blame the hormones, right? Anything goes wrong. Well, you're on hormones. No wonder you got into a car accident, right? Like this is just the craziest stuff that happens. Now, as far as like blood work, like what kind of things do you look at when you're deciding, for like your initial consults, for instance? What kind of markers do you value the most?
Yeah, absolutely. So for women, I will get a baseline FSH and LH that kind of tells me what the pituitary is doing. I will check an estradiol and a progesterone level. If they're still a cycling female, those levels are going to vary depending on where they're at in their cycle. So they're not of huge diagnostic value in regard to perimenopause, but it will give us some kind of baseline and it will tell us if there is something more concerning underlying rather than just perimenopause going on. If something is sky high or if something is just really in the toilet, then if it's an unexpected range, then that tells us, hey, we need to dig a little bit deeper and this may not just be perimenopause. And then in regards to testosterone, so I check a total and a free testosterone, and I base my treatment off of one, symptom resolution. Symptom resolution is always going to be the priority. Symptom resolution, minimizing side effects, and then kind of taking into account those lab values. You want to make sure that the patient feels good, but that they're still being safe.
Yeah, what are your thoughts on timing of labs? I've heard some practitioners say, I only get these labs on day 20, so we know we're in the luteal phase. What are your thoughts? Do you think there's any value to timing these labs, or does it not matter?
Personally don't. I will just get labs and then I kind of will correlate that with the patient. I will ask them if they're still having regular cycles and what day was this that we drew their cycle to see if that correlates to where they were in regards to their labs and their cycle. But not really. I mean, because I'm going to treat them regardless. If they're having symptoms of perimenopause, if they're having night sweats, if they're having increased anxiety, if they're having increased irritability, I'm still going to give them progesterone.
Right.
Not going to change my plan. But I do think it does help some patients to have that kind of reassurance, to have objective data to look at, to know that nothing is extremely out of whack.
Sure. I couldn't agree more. I mean, by the time they're coming to us, they've already suffered so long. And now we're going to say, hey, sorry, you're going to have to suffer for 20 more days till we can get some blood work, right? It makes absolutely no sense. And the other thing, too, is with the blood work. How do you address when the hormones are technically normal?
Yeah, that's a great question. So, in perimenopause, your levels can fluctuate so much. So, I don't base treatment off of the lab values at all, unless I am reevaluating treatment and I'm concerned that perhaps we're super therapeutic in regards to estrogen. If they're having, symptoms of excess estrogen or for testosterone for women, there's different treatment goals and there's different goal ranges. So I don't focus so much on the total testosterone. It's more of the free. And I will kind of get them anywhere between 5 and 15, depending on where they feel good at, and making sure, of course, that their side effects are minimized. So, and I always tell patients, look, in exchange for better mood, better libido, better energy, increased, brain clarity and cognition, you may have an extra chin hair that you need to pluck, and it's okay. It's worth the trade-off, and I will tell you that about 99% of the women, whenever I come back for their follow-up, they say, "I don't care if I have to shave my head. You're not taking my hormones from me."
Yep. I hear it too. I hear the same exact thing because it's just so amazing to finally feel like yourself again, right? And I mean, you're not going to give that up for anyone. So, one final question. How do you address as far as breakthrough bleeding? What's that? How's that conversation usually sound?
Yes, perfect. That's a really good question. First, I tell all of my women patients if they still have a uterus, if they're still cycling, adding hormone therapy, about 20 to 30% of women will experience some kind of spotting, some kind of breakthrough bleeding, but just be patient and we can work it out. Usually that can happen in the first 6 months, not so common after we're about 6 months in. So if you start to have some spotting, I'll tell them to double up on their progesterone. We'll do that for about 4 or 5 days. Usually that is enough to kind of resolve the spotting. If the progesterone doesn't, if the progesterone does not resolve the spotting, or if they continue to bleed or increase in bleeding, then I also will determine if they need a transvaginal ultrasound. So we'll measure their endometrial lining to see if that's too thick. Sometimes that can be the reason of bleeding, or if they've developed any kind of fibroids or polyps or endometriosis. Women who have had a history of fibroids or any kind of proliferative tissue disorder in the past, those are usually the women that I see have issues with spotting and breakthrough bleeding. So I kind of forewarn them. Look, you've had this problem in the past. If we add a little bit of hormone therapy, it is likely that you're going to have some breakthrough bleeding. So we may just need to put you on higher doses of progesterone to kind of keep that uterine lining really thin. But don't panic. There's ways that we can address it. Double their progesterone for a couple of weeks. If that doesn't work, we'll get a vaginal ultrasound to check their uterine lining. If that doesn't work, we can add tranexamic acid for a few days to kind of knock that bleeding out. Then if that doesn't work, then it's probably time that we call the gynecologist.
Yeah. And that's awesome, because that can be very alarming, right? Someone who's postmenopausal, now they're starting to bleed. The thing is, it's not the bleeding itself is the inherent problem. It's that, are we masking another problem that needs to be addressed? You never know. And so, yeah, the bleeding is something that, it's not normal. If you're on continuous hormone replacement therapy, bleeding is not normal after a point. We try to keep these episodes pretty short. Crystal, what is one piece of advice you'd like to give to anyone who's kind of on the edge of, should I get my hormones checked? Should I not? What is one thing you would say to them to kind of help them make a better informed decision?
I'd say if you had a choice and you could do one thing that would decrease your risk of these chronic diseases, heart attack, stroke, multiple cancers, Alzheimer's, why wouldn't you? If you know that there is one thing that you can do to decrease your risk for all of those horrible chronic diseases, why not? And also get some relief
Absolutely.
out of it. It's not that it's just about helping you to feel better, but it's also helping you to live longer and to live a more functional life down the road. We want to avoid having to be frail and live in a nursing home. That's not a life. You want to have as much active, enjoyable, functional years as you can.
Awesome. Crystal, thank you so much for joining us today.